Hello and welcome to today's presentation on cervical incompetence. This is a very important condition, and so we are going to look at the risk factors, how to diagnose it, as well as how it is managed. So, when we say cervical incompetence, we mean the inability of the uterine cervix to retain the growing product of conception, leading to spontaneous and painless cervical dilatation, preterm delivery, as well as pregnancy loss. Now, this condition is very important because uh, approximately 15% of all second trimester losses are due to cervical insufficiency or cervical incompetence, which is quite high. Now, what are the risk factors to this cervical incompetence? We have both the inborn as well as the acquired causes or risk factors for cervical incompetence. And so, with the inborn uh, risk factors, we have uh, factors such as congenital anomaly of the cervix, which may include cervical agenesis, dysgenesis, as well as cervical obstruction. We may also have exposure to diethylstilbestrol in utero. Now, this diethylstilbestrol is a synthetic non-steroidal form of estrogen, and it's a well-known teratogen and a carcinogen. Now, this agent works by blocking the synthesis of testosterone, thereby lowering the plasma concentration of testosterone and inducing a chemical castration. Now, a lot of studies have found that some women develop malformation and hypoplasia of the cervix due to exposure to this agent, which is diethylstilbestrol in utero, and go on to develop cervical incompetence or insufficiencies during the second trimester of pregnancy. This is important because it is for the obstetrician to be aware of this potential complication so that it can be avoided in the second trimester through the use of some prompt surgical interventions. Then we may turn to the acquired risk factors, which may include cervical tears following childbirth. Then we may also have overdilation and trauma to the cervix. This overdilation and trauma to the cervix is usually, seen during dilatation and curettage, which is usually performed during surgical termination of pregnancy in the young premigravida or even any other woman who undergoes such procedure. Then we may also have exposure to diethylstilbestrol again as an acquired, risk factor. Then also we have conization or LEEP. When we say LEEP, it refers to loop electrosurgical excision procedure. And this conization or LEEP uh, is done for diagnostic purposes in cervical cancer, and it may predispose to cervical incompetence, especially when the parts of the cervix which were taken are too large. Now, a Norwegian cohort study, of more than 15,000 women with cervical conization found a fourfold risk of pregnancy loss before the 24th week of pregnancy. So this poses a high risk, to cervical incompetence that we must also pay attention to. Now, when we look at the diagram or the flowchart on our right, what we find is, so over here we have the inborn risk factors as well as the acquired risk factors. And so whether through inborn or acquired means the woman is predisposed to an incompetent cervix. And so as pregnancy advances, the increasing weight from the growing fetus coupled with increased intra-abdominal pressure precipitates painless uterine contractions, which causes the fetal membranes to bulge into the cervical canal, and this is what we refer to as funneling. And eventually, this may lead to second trimester pregnancy loss or even premature delivery of the baby. In addition to this, as the intrauterine pressure increases, we find that the cervix dilates, the fetal membranes are exposed to vaginal flora, and increase, the risk of trauma. And so, usually, the vaginal discharge and rupture of membranes are common findings in the settings of cervical insufficiency or incompetence. Some patients may also present with short-term cramping or contractions, which will lead to advancing cervical dilatation or pressure in the vagina with chorionic and amniotic sacs bulging through the cervix, which we refer to as the R-glassing. And so, as they bulge through the cervix, uh, they enter into the upper portion of the vagina within the second trimester. And with time, the membranes will rupture, and ultimately, spontaneous expulsion of the immature fetus will take place, or spontaneous abortion will occur. So that is it. So when we look at this diagram is actually showing us a weakened cervix. As you can see, the cervical canal is widely, opened, and the fetal membranes are bulging through the cervical canal into the upper portion of the vagina. So, how do we evaluate and diagnose a woman with cervical competence? Usually, a history of recurrent pregnancy loss after second trimester and a history of cervical dilatation after second trimester without uterine contraction may be pointing towards cervical incompetence. And so, when a woman presents with such history, you must have a high index of suspicion that she might be having incompetent cervix. And in this situation, we may do a transvaginal ultrasound. And in a late first trimester scan, an opening of the cervical os at rest, as well as the application of mild fundal pressure to the abdomen is considered. So, how do we evaluate and diagnose a woman with cervical incompetence? Usually, a history of recurrent pregnancy loss after second trimester and a history of cervical dilatation after second trimester without uterine contraction points to cervical incompetence. And so, when a woman presents with such history, you must have a high index of suspicion that she might be having an incompetent cervix. And in this situation, a transvaginal scanning is required. And in a late first trimester scan, an opening of the cervical os at rest or in response to fundal pressure is considered an early feature of cervical incompetence. Now, when we do the transvaginal ultrasound, what we find is the bulging of the fetal membranes into the widened internal os, and this is usually considered as the most reliable sign of the diagnosis of cervical incompetence. And so we may find what we call funneling, and funneling is the ballooning of the membranes into the dilated internal os, but with a closed external os. And this indicates cervical incompetence. And so, looking at the diagram on our right, we find the various types of cervical incompetence as the T, the Y, the V, as well as the U. And so, with the T type of cervical incompetence, as you can see, the shape looks like a T. So, we have the internal os mildly open as well as the cervical canal, but as you can see, the external os is closed. In the Y type of cervical incompetence, it looks like Y. So the internal os is opened and the cervical canal has started dilating, yet the external os is still closed. And the V type of cervical incompetence, we find the internal os widely opened as well as the cervical canal also opening, but the external os still closed. And finally, the worst form of it all is the U type of cervical incompetence, where the internal os is largely opened as well as the cervical canal, yet we have the external os closed. So these are the various forms of cervical incompetence that we may find when we do ultrasound. Now, we may also measure the length of the cervical canal. Now, we can measure the length by measuring the distance between the external os and the internal os. As we know, the cervical length changes as pregnancy advances, and there is evidence to suggest that a short cervix is related to preterm birth. And this relationship is further strengthened if there is a history of preterm birth, or even if a progressive shortening of the cervix is noted during pregnancy. Now, normally we find that by the 16th to the 24th week of gestation, the cervix is, or the cervical length is 4 to 4.5 centimeters long, or 40 to 45 millimeters. By the 24th week to the 28th week of gestation is around 3.5 to 4 centimeters. And by the 32nd week of gestation to the 36th weeks, we find the cervical length to be 3 to 3.5 centimeters, or 30 to 35 millimeters. And so we say that on an average, the normal cervical length should be at least 30 millimeters, or 3.0 centimeters in length. And so cervical incompetence is defined when the cervical length is less than 25 millimeters, or 2.5 centimeters at or before 24 weeks of gestation. Now, an important thing for us to note over here is that the risk of preterm delivery is inversely proportional to the cervical length. And so, with a cervical length less than 25 millimeters or 2.5 centimeters, you stand an 18% chance of preterm delivery. If we have a cervical length less than 20 millimeters or 2.0 centimeters, you stand a 25% chance of preterm delivery. And a cervical length below 50 millimeters or 1.5 centimeters stands a 50% chance of preterm delivery. So as you can find over here, this is the fetal presenting part, putting pressure on the internal os. But as you can see, it is firmly closed, as well as the cervical canal is closed. So this is how the normal cervix looks like. This part being the fetal membranes, and this being the fetal head. And you can see that the cervical canal is tightly closed, the internal os is closed, and the external os is also closed. Now, in an abnormal cervix, where we find that the cervical length is shortened, you may also find that the cervical canal is mildly open over here, and so this may pose a threat to the woman in the form of cervical incompetence. Now, there is still another test that we can do, which we call the fetal fibronectin test. Now, we do this test, and we use vaginal swab to estimate the risk of preterm labor. Now, this fetal fibronectin is found at the junction of the chorion and the decidua, that is between the fetal sac and the uterine lining. And so you can think of it as an adhesive or a biological glue that binds the fetal sac to the uterine lining. Now, the fetal fibronectin is found in vaginal fluids in early pregnancy because of the normal growth and establishment of the tissue at the junction of the amniotic sac and the uterus. But the levels usually fall when this phase is complete and as pregnancy advances. And so we are not supposed to detect fetal fibronectin between the 22nd and the 35th week of pregnancy. And so if it is found in the vaginal fluid around this period, it may indicate that the woman is at increased risk of premature birth within 7 days. This fetal fibronectin may be found, in the vaginal fluid after the 36th week of pregnancy, since the body is now preparing for childbirth. And so, in summary, this is the entire evaluation as well as some diagnostic, steps that we take in cervical incompetence. Now, on this slide, I'm going to show you some ultrasound features of cervical incompetence. But firstly, this is the normal cervix as we find in pregnancy. And so this being the fetal head, amniotic fluid over here, the asterisk over here pointing to the internal os, and here being the external os. And as you can see, we have the endocervical canal firmly closed, here being the vagina. On this slide, what we find is that we find a T type of cervical incompetence. As you can see, it looks like T. So the asterisk here is the internal os, and here is the external os, and you can see that fluid is filling the cervical canal, here being the edges of the placenta. Then over here we have the Y type. So as you can see, it looks like Y. Then we have the external os over here, then the internal os over here, and you can see that the cervical canal is mildly opened. In the V type, you can also find it over here. Then the U type, there is a complete opening of the internal os, as you can see, one asterisk over here and another over here, wildly open, and the fetal membranes bulging outside. Now, on this diagram, on this ultrasound, we can find the bladder over here, with this being the fetal head and this being the edge of the placenta. And this is a T type of cervical incompetence. And so we can have our internal os over here, as well as the external os over here. And you can find some fluid inside the cervical canal. And this is what we call the R glassing, when there is complete bulging of the chorionic as well as the amnion into the upper portion of the vagina. We call it the hourglassing. And on this slide, we find an ultrasound scan at 18 weeks of gestation showing a T type of cervical incompetence, as the arrows are pointing over here. And by the 25th week of gestation, we found that the internal os was widely open and the membranes were bulging. So as you can see, this being the external os, the membranes are here, and the fetal head, also over here. So these are some ultrasound scans showing cervical incompetence. So how do we manage patients with cervical insufficiency or cervical incompetence? Ideally, we must make sure that we treat all cervical infections, including gonorrhea and chlamydia. Also, other measures that we need to consider may include ensuring bed rest, as well as the use of some tocolytics. Tocolytics are going to help us to prevent the uterus from contracting. And so common tocolytics that we use include indomethacin, nifedipine, magnesium sulfate, and terbutaline. We may also give steroids, to help with fetal lung maturation, and also for at least a week before and after surgery, we must make sure that we avoid sexual intercourse. Now, if the patient with cervical insufficiency had a preterm birth, which is usually the case, it is also common to treat her in the subsequent pregnancies with intramuscular 17-hydroxyprogesterone, weekly until the 36th week of gestation. This practice is, however, controversial, and it's not practiced almost everywhere. Now, with classical cervical incompetence, we manage it surgically with the use of cerclage. And so, with cerclage, what we do is there is, or it involves, the insertion of a purse string suture around the cervix to prevent the shortening and dilatation of the cervix. Now, cervical cerclage may be performed either transabdominally or transcervically. However, we find that transvaginal cerclage is much more common than the transabdominal cerclage. Now, transabdominally, we place the cerclage at the 11th week of gestation, either by laparotomy or laparoscopy. And laparoscopy is now encouraged because we may have to, avoid the need for major surgeries. Now, this transabdominal cerclage is indicated where there is a history of a very early preterm birth despite previous transvaginal cerclage, or where there is insufficient cervical tissue for the transvaginal stage to hold. And so these are the indications for us to do transabdominal cerclage. With transabdominal cerclage, delivery is by cesarean section within, with the uterine incision made above the level of the suture. And so it is important to note that all women with transabdominal cerclage require delivery by cesarean section, and the abdominal suture, and the suture which we used for the cerclage may be left in place following delivery for subsequent pregnancy, such that we do not need to do further cerclages for this woman. Now, transvaginally, the cerclage may either be McDonald or Shirotka. McDonald was first made and it was modified by Shirotka. Now, with these two techniques, it is done between the 12th and 14th week of gestation, and it must be removed before labor, usually between the 36th and 37th week of gestation. And with Shirotka suture, we may need to remove it with the use of some form of anesthesia. Now, we also have what we call emergency cerclage. Now, emergency cerclage is usually done when, as the name implies, as an emergency, and we usually do it when there is cervical dilatation and bulging of the fetal membrane, in mid-trimester. And so we do it in an attempt to prolong the pregnancy to a viable gestation. This being said, emergency cervical cerclage is likely to increase the risk of infection due to the increased exposure of the fetal membranes to vaginal bacteria. Also, we find that its effectiveness and the safety still remains controversial. And so, even though it's not a very common practice, it is, a procedure that can be done to prolong pregnancy. Now, before we continue, I would like to stress that the Royal College of Obstetricians and Gynecologists recommend that delayed removal of the cerclage for 48 hours can be considered in women with preterm premature rupture of membranes between the 24th and 34th week of gestation and without evidence of any infection or preterm labor. Now, they say we can delay it because it will help us buy time or buy sufficient time, during the latency period, which we can use to enhance the prophylactic use of steroids to help with fetal lung maturation. However, given the risk of neonatal and maternal sepsis and the minimal benefit of only 48 hours of latency, during a pregnancy with preterm premature rupture of membranes, usually before the 23rd and after the 34th of gestation, delaying the removal of the suture is unlikely to, be advantageous in this situation. And so, though it is recommended, you have to weigh the risk of, infection to the advantage of fetal lung maturation, and you go ahead to, implement it. Now, when we look at the diagram on our right, this is the various forms of cerclages that we have. So the upper one being the transabdominal cerclage, which is quite high. Then the transvaginal cerclages, which include the Shirodka cerclage and the McDonald's, are also found over here. So these are the basic management techniques that we have for cervical incompetence or insufficiency. Over here, I tried to show different forms of the cerclage. The first one being the McDonald's, and with the McDonald's, what usually happens is that a circumferential suture is inserted anteriorly at the junction between the ectocervix and the vagina, and so the needle is placed over here. So you take a bite from this place, you come out, then you go inside again, you come out, then so you do this, and you do it in a circumferential manner. Then your last suture comes out to where you started. Then you make the ligation over there, or you make your knot over here. And so this is where you are going to tie the knot. And this is able to keep the cervical canal closed and keep the pregnancy till term. Now, with the Shirodka, as you can find over here, usually what happens is that a transverse, a cervical cerclage, sorry, with a Shirodka, what happens is that an incision is made in both anterior and posterior parts of the cervix. So you can see an incision being made over here. Similar incision is made posteriorly. And after this dissection or incision is made, we have, the suture being, taken through it, as you can find over here. So you take a bite from here, then you go down, you suture, then come outside through the other edge of the suture, then you tie. So this is how it finally looks like. So this is how the needle was entered, and this is how the thread or the suture passed through it, and it was ligated outside like this. So these are the various ways of performing both the McDonald and the Shirodka cerclage. Now, what are some of the complications of this procedure that I've just explained? The cerclage. Usually, it can lead to bleeding, which is obvious because we are going to do suturing. Then, we may also have infection, which may ascend into the endometrium, causing endometritis. We may also have increased frequency of contractions because we've tempered with the cervical os, and so the suture is seen as a foreign body, and so the uterus tries to contract frequently. Then we also have cervical trauma, which is obvious because we are, tempering with the normal tissue of the cervix, and through the suturing, we may inadvertently cause trauma to the cervix. Then we may also have the premature or the preterm premature rupture of membranes. This this may occur as the procedure is being done, and it may not be done, intentionally. So it is the unintentional rupture of the membranes, especially if the membranes are bulging so high as we find in both the V type and the U type of cervical incompetence. We may also have the suture being displaced sometimes. Then we may also have sepsis as a complication of cerclage. Usually, this sepsis may lead to both maternal and fetal deaths. Now, we may also have cervical scarring, and this usually may occur after the cervix has healed post the procedure. We may also have another complication such as the need to place a cerclage in each gestation, because the first pregnancy required cerclage, and so subsequently we may need to still put a cerclage, which is a complication. Then an important thing that I want to draw your attention over here is that in addition to all of these complications, transabdominal cerclage has been associated with pregnancy loss and fetal growth restrictions from inadvertent ligation of the uterine arteries. So as we do transabdominal cerclage, these are some of the complications that we may encounter. Now, it is also important for us to note that all of these complications that I've just explained are uncommon when the cerclage is done prophylactically. And so it is very important that when we are sure that the woman is having cervical insufficiency or incompetence, we quickly must go in and do this cerclage so that we can prevent most of these complications from occurring. It is also known that perioperative antimicrobial prophylaxis has failed to prevent most infections, during the pregnancy as a result of this cerclage. And also the use of these tocolytics failed to arrest contractions, and so labor continued. A lot of studies have also suggested that clinical infections mandate immediate removal of the suture. Then we go ahead to augment labor, or we go ahead to induce labor. Also, when there is imminent abortion or delivery, even though there is still cerclage, we have to remove the suture immediately, because uterine contractions can tear through the uterus and the cervix to cause much more damage to this patient. Now, what are some of the contraindications to the cerclage procedure? The first one that we can talk about is fetal anomalies. When there are anomalies of the fetus, why would you want to keep a fetus which has some anomalies? You may even want to bring it out, and so we don't encourage the use of cerclage to keep a fetus which has anomalies. Then also, when there is intrauterine infection, you wouldn't want to keep the infection for long, because if the infection stays there for long, it will eventually lead to endometritis, as we just explained. Then also, when there is active bleeding, you may want to find out where the bleeding is coming from, and so you wouldn't want to suture the cervix to keep the blood inside the uterus. So obviously, if the woman is bleeding, you wouldn't want to suture the cervix. So it is a contraindication to the use of cerclage. Then also, when there is preterm premature rupture of membranes, you wouldn't want to do cerclage. A significant risk of premature rupture of membranes is that the baby is very likely to be born within few days of the membrane rupture. Another major risk of this premature rupture of membranes is the development of serious infections of the placental tissue, which we usually call the chorioamnionitis. And so it may carry a very dangerous risk of infection to both the mother and the baby. So if there is prom, why would you want to, do cerclage for this woman? It doesn't make sense because the baby, whether you like it or not, may come. So why would you want to suture the cervix and keep the baby over there in the midst of all these risks of infections? And finally, we may also talk about fetal death. Obviously, why would you want to keep a dead fetus in the uterus? You wouldn't want to do that. And so it is also a contraindication to cervical cerclage. Now, the last few words I would like to leave with you is that the more advanced the pregnancy, the greater the risk that surgical interventions through the use of cerclage will stimulate preterm labor or even, rupture of membranes. And so, usually, uh, it is not advisable to perform cerclage after the 23rd or 24th week of, pregnancy. This is controversial. This is controversial because most hospitals still, go ahead to, place cerclage for their patient. So I think this is all that I have for you, and I want to say thank you very much for your attention. Bye bye.